So you all can hear me. The topic which I think I had taken for this session, this batch only one earlier class on laboratory diagnosis of viral hepatitis. Now, National Viral Hepatitis Control Program in the country. So this is again a repetition that why everybody was thought of working on hepatitis B and C. As you can clearly see that it was in the year 2017. Globally, everybody saw that more than HIV, tuberculosis, malaria, it is hepatitis B and C where the cause of deaths are rising, and that need a lot of attention. So there is a global health sector strategy. How the internationally bodies they work is that you have WHO. They take information and data from several countries. Then they raise the issue, and then they request each government to start taking action. So this global health sector strategy laid down certain goals that number of new cases caused by B and C should be reduced at least 30% reduction by 2020 and 90% reduction in them by 2030. Deaths which are caused by B and C should be reduced substantially, that is 65% by 2030. Although when this was started in 2017, we were not aware of that all countries would be hit by this COVID-19 pandemic. But that has slowed down the effort, but still we have the target to bring down the new infections by 2030 and number of deaths caused by B and C, and India is the signatory to it. So these are the targets which globally WHO has set up for each and every country. Now, these are the baseline information and what we need to do by 2030. Like hepatitis B vaccination, which is starts with birth dose vaccination, it has to reach to 90% coverage. Everybody has started working towards it. Blood safety means checking each and every donation for hepatitis B and C infection. I think 97, 98% we have achieved, but it should reach to 100%. What is lacking is hepatitis B and C diagnosis, which is just 30%, and it should reach 90%. And then subsequently, treatment, offering the treatment to B and C infected is very, very poor globally. It's 8%, 7%, which has to reach to 80% by 2020. So for B and C both, again, I'm telling it to you that major gap is that how will you put more and more patients to treatment only if you diagnose them more. So look at the percentage gap in those who are being diagnosed. So that is why this was a problem which was laid down by the government of India also, and we decided that you really need a well-documented action plan so that you can control this problem of viral hepatitis. What ILBS did, since ILBS is a WHO collaborative center, from the year 2014, 15, 16, and 17, you can see we held meetings with the government of India and WHO, and we did a lot of on every 28th of July, which is the World Hepatitis Day, we used to do these meetings like towards comprehensive national plan, then towards a national action plan, and then national consultation on viral. So we did all these brainstorming sessions for 4 years. And finally, in 2018, the government of India has launched this National Viral Hepatitis Control Program in the country. So this was launched in 28th of July 2018 by then Health Minister JP Nadda ji, and we all, as I told you, from 2014 onwards, we were working towards development of these guidelines. And all these guidelines, if you log on to the Government of India website or just write down National Viral Hepatitis Control Program guidelines, all these PDF and free guidelines are available. Now, these guidelines are on to be done? What is this control program? How do you diagnose and manage a case of viral hepatitis? What is the national action plan? And initially, the government of India did not want to launch for B. We only covered hepatitis C into it. But then in 2019, the hepatitis B component was also added. So our country's National Viral Hepatitis Control Program is the only program globally where complete treatment, management, diagnosis, everything is included for B and C patients and at free of cost. So, what are the aims of this program? Now, the thing is that it has been launched in 2018 and 2019. The meetings were held by Government of India, and various sessions were held. We identified states, we identified the state nodal officers for each state. But when we were doing this process, early 2020, COVID pandemic came, and so 2020, no work. The work did not progress, and 2021 also it got hindered. And now again, a few states have taken up, and there are a few sites which have been identified. Training is there, funds have been moved. So we hope that in the next couple of years, it will be very fast and there will be a fast uptake. What are the aims? Like, what are we going to do under this program is that we are going to look after hepatitis C in our country, and we would target elimination by the year 2030, means identifying maximum patients of hepatitis C, putting them onto treatment so that they attain SVR and the virus is cleared from them. We are going to reduce the infected population caused by B and C, because B you cannot totally eliminate, but we are going to actually pick up cases of B, treat them, those who require treatment, and so that the viremia is controlled in them. We are also going to look after A and E in way of that you reduce the risk, and in case there is a mortality or morbidity, severe morbidity associated with the A and E, then that needs to be taken care. So basically, the first and the foremost target in front of national program is elimination of hepatitis C. Then B, putting as many patients into cascade of care as possible, and then also looking after A and E. Now, this program, now there are many programs you are all aware of in our country. You have a very good national AIDS control program, that is NACO. Then you also have a national TB program through RNTCP, it runs. You have malaria control program. Now, whenever a government makes program, they make different working style of that program. Like NACO is a independent body. They have their own sites and centers. They have their own funding in the central ministry, and they give funds for diagnosis, treatment of HIV. They have made ART centers. Now, how this viral hepatitis program is going to work is this chart I'm going to tell you. At the national level, where you have this Government of India, where the chief secretary, and this program is controlled through the National Health Mission. There is a National Program Steering Committee, and I'm one of the members of this National Program Steering Committee. They have made a National Viral Hepatitis Management Unit, and this unit sits at right now the Secretary Health, Additional Secretary Health, and one of the doctors, Dr. Sandhya Kabra, who is in NCDC, she controls this National Viral Hepatitis Management Unit. So Government of India controls this. So they have 3 or 4 technical resource groups, and then the meetings are done by these resource groups. All the guidelines have been formed by these resource groups, and now they are on a hunt that which state they have to involve, and in each state, so they will be looking after how many states to involve, who will be carrying out this program in the state. Now, what happens at the state? Like I can tell you, Delhi state has still not launched it properly, but there is a state program steering committee which has been made. Fortunately, I am a part of this Delhi state program committee also. So now the message has gone from the national to all the states in India, that please identify a committee and we will give you funds and you start diagnosis and treatment of hepatitis B and C in your state. Now, each state makes a committee. They make a state viral hepatitis management unit. They identify their treatment centers, and usually medical colleges are being involved by the state because they have the entire gastroenterology, microbiology, and radiology support. So mostly it is the medical colleges where they have made these model treatment centers. So the fund which comes to them, they give it to them. And then you can have separate state lab, or along with the medical college, you can identify the labs where all the PCR tests, etc., will be done for that state. Now, there is a provision. You can also involve private lab, but your state has to agree, and you can make as many treatment sites as possible in your state. But all this decision is taken by state viral hepatitis state health mission. So this comes under national health mission and state health mission. Now, these states can make 1 or 2 medical colleges as their sites, or they can identify certain at the district level, the treatment centers, their primary health centers, whatever centers they can identify, they all will come under the state. So the idea, what was started in 2018 was making this committee and guidelines. Then in 2019, all invitation to all the states had gone. Many states have actively taken up. They have made the program committee. They have taken funds. They have started they have made viral hepatitis B and C viral load free, and treatment for B and C free. The drugs are available, and ideally the idea is that from these states it should go down to the primary health center site or district site, so that the medical officers sitting here, they can treat anybody who is infected with B and C. Now, the basis of this program is that the screening offered under this program, which it will be serological test, that is rapid guard test for B and C. If anybody turns out to be positive for HPSAG or anti-HCV, then DNA, HBV DNA or HCV RNA will be done. So the molecular test in the form of RT-PCR tests are made available. Uncomplicated cases, if the liver is non-cirrhosed, then the treatment can be given right from the district hospital side. In case there is a complication, then as I showed you, that there is a model treatment center, which is a medical college, the treatment will be given up at the model treatment center side. This is the plan, simple plan for this. Methodologies, usually the card test we are going to use. In case medical college wants to buy some ELISA, then the budget is there for them to buy ELISAs. For only viral load testing, RT-PCR based instruments are allowed under this program. So this is how the diagnosis works in NVHCP at a primary health center in your state. The government will provide free rapid card test for B and C. There'll be just rapid card test. In case there is a doubt or query, then they'll be connected to district hospitals where a provision of ELISA can be provided for confirmation of the results. Otherwise, most of the diagnosis by B and C will be there. And they will also have a linkage to RT-PCR. Either they can do the RT-PCR or they can have a bigger state lab where they can send the sample and get an RT-PCR for hepatitis B and C done. And so that the report can be given to the doctor sitting at PHC or districts. Then there'll be higher labs like Center for Excellence or Sentinel side, where budget will be provided for sequencing or CLIA-based techniques in case there is a discrepancy. Otherwise, most of the work can be done at the primary health center as well as the district level sites. Treatment at the sub-district site, to the PHC, the drugs can be provided So in case you are a district hospital, you are the in charge, you can contact your state health mission and can say that please make us one of the drug dispensing sites for B and C and testing sites also. So wherever an RDT is done, the viral load information can come from the hospital to them, and you can start the patient on treatment for non-complicated cases. Now, in case uncomplicated cases, you can give at the district hospital, but complicated cases should be referred to a medical college or a specialized center where provision for endoscopy or a detailed ultrasound facility should be available, so that the complicated cases. So this is how the treatment has been proposed to work for under this program. Now, the most important challenge is that linkage and continuity. So, first thing is that these sites should be identified. So each state should take the responsibility. And as I told you, like I am a part of the national program and Delhi state, and still now Delhi state has not taken up actively. We have made committees. We have free drugs available. We have budget for getting hepatitis B DNA and RNA free, but they have actually not officially identified the sites so that a patient comes into the program and then is retained into this program. So it is the onus goes on to the state, how actively that state takes up this program, because they can take any amount of budget from the government, from the national for doing this program into their state. And then once a patient is put, then the linkage and continuity has to be maintained. So you have to actually follow up that at least for hepatitis C, that the 12-week treatment has to be taken. And B, if the person is not put on treatment, then he's coming regularly and getting his ALT and DNA test done, and so that we can follow him. So this is the problem of linkage and continuity. He has to take this program and then become the nodal officer in that state to run the program successfully in that particular. So this is the main problem why we have just identified the training is going on. Actually, the kickstart and has not started in many states. This is a problem which we are seeing right now. The drop-off occurs, people get their RDT test done, and but they never turn up to get the PCR test, because if you have RDT test done in 10 places and the RT-PCR lab is only one in your state, then this problem is going to come. So that is why you should have more and more RT-PCR testing sites in your states so that patient is maintained in the cascade of care. Then result communication, which we are seeing that most of the microbiology labs, even if they do a viral load, they do not send the result of timely, and so the treatment initiation and follow-up is not done. Another important problem in this program is that the complicated cases, like uncomplicated cases, everybody is willing to give them treatment. But once it comes to complicated, then proper referral and guidance is not provided, where to send that patient. And then patient has to do everything free of cost because this is a program. So this kind of clarity has to be given in each state. So I'm not saying that we cannot do, we can actually do, but first thing is that the state, the government, that state government has to be very clear that whosoever they make the in charge for this program, that person has to be take a big responsibility that any patient who comes and gets enrolled, then the entire follow-up is given and the treatment is given. And that is why probably the reason that it is not yet started to the full-blown way that we anticipated, that now it is 2022, it should have really started, but there are a lot of hindrances which we are seeing are happening at the state level. Now, what are the guidelines we follow? I think I have already told you for hepatitis B and hepatitis C. Hepatitis B under the program. So here, minded that when you are doing an individual patient care, you can do as many tests as possible. But when you have a free program, then whatever tests are given in the free in that program, you are going to use them only, and then follow the guidelines strictly. So in this program, hepatitis B surface antigen for hepatitis B virus is the diagnostic marker. That is the first test we offer. Confirmation, if turns out to be positive, then you have to go ahead and get a DNA. Rest all tests do not come under the free program scheme. They can be there in your individual management, but they are not there. This I have already told you, so I'm skipping. This is the guidelines, the same, which is WHO guidelines also, and this is our national guidelines. So you first offer, so the first point of contact, if a patient walks in and says that I want to get myself tested for hepatitis B and enrolls into the program, you're going to offer him only HBsAg, and that to a card test. That is the provision. Now, if the patient turns out to be positive, then you're going to look for the liver health by clinical criteria, non-invasive scores or fibroscan, APRI, whatever is free of cost available in that medical college. And if it is not available, you can ask your state that please provide us with these so that I should be able to know whether the patient is cirrhosis or there is cirrhosis or not. So if a patient is HBsAg positive cirrhosis, the treatment has to start. And the drugs which are given are tenofovir or entecavir under this program. These are the only battery of drugs, and you have to give. Now, if the patient is non-cirrhosed, then you have to go by the age, you have to go by the ALT and the viral load, HBV DNA viral load. If age is more than 30 years, ALT is abnormal, viral load is more than 4 log, the treatment needs to be started. If other thing like ALT is intermittently abnormal, normal, or age is less than 30 years, you just do not start hepatitis B treatment. You monitor the treatment. Now, how do you monitor? Now, once patient is in this category, you will call the patient at least once a year. This is under the program. Now, if your patient is paying for it, he can come as many times as possible. But if you are giving him free test and treatment under the program, call him at least once a year, get his ALT and DNA done so that you identify whether now still he requires to be put on treatment or not put on treatment. If the patient is put on treatment, then you have to call him 3 monthly, get his DNA done so that you know the response to treatment. In case the patient E antigen will not be provided under the program, but in case you have got it done, then you can monitor him with E antigen and antibody to E to know his response. But only ALT, DNA, and HBsAg will be provided, and baseline pre-treatment investigations under the program to manage hepatitis B cases. These are the drug options which are available in the program. TDF is also available, TAF is also available, and entecavir. So these are the only drug options which are available. If you have to start a patient on interferon, then the cost has to be borne by the patient, and automatically the patient goes out of the program. If you want to include him, then these are the drugs only which will be given, and you have to manage the patient on this. This is what exactly in the national guidelines it has been given and mentioned, that how the flow will be there when the patient presents. This is how I told you treatment. Patient can be treatment naive or he can be treat experienced also. It is not that a person who is known hepatitis B and is being taking cannot be included in the program. You can still include him and then start following up. And so if your site, if you are working in a district hospital or a medical college and the state government identifies your site as one of the treatment center, then that doctor will get one data entry operator, a lab technician from the program, and this is the work they have to do, means keep on calling the patient and put him into the cascade of care, right? Now for hepatitis C, the hepatitis C is a simpler virus, as I told you. You just have to do an antibody test for hepatitis C, and You just have to put get a RDT test done for hepatitis C. If patient is positive, report positive, get an RNA test done. RNA is positive, you have to put the patient on treatment. It's very simple. If antibody is negative, report negative, and you don't have to get an RNA test done. These are the treatment available under the program. If patient is without uncomplicated, then NS5B inhibitor in the form of sofosbuvir and declatasvir is given for 12 weeks. If there is cirrhosis, then velpatasvir is given. If it is decompensated, then ribavirin will also be if a patient gets enrolled in hepatitis C, you just have to give a 12-week course to the patient. Now, it depends upon you. You want to give monthly package of drugs, or ideally, it is better to keep on calling the patient after every 4 weeks. And then after 12 weeks, when the treatment is completed, you tell him to wait, and then call him again after 12 weeks to take his viral load sample for an SVR12. In between, there is no need to monitor or do any test on the patient. And genotyping, and in the national program, and only in case the SVR is not attained or it is a complicated case, then apart from the program, when patient get a drug resistance or a genotyping test done. This is how the algorithm has been given for hepatitis C. Again, here treatment naive as well as treatment experience, both kind of patients can walk in. They will be enrolled, and the anti-HCV and HCV viral load is the only test which we do, and do an SVR after completion of 12 weeks of treatment. So it's a very simple algorithm with which hepatitis C is going to be managed under the program. For E virus, as I had already told you, the lab diagnosis is usually by IgM serology. So in this program, for acute viral hepatitis, HEV IgM is the one test which has been recommended. For A virus also, because IgM is a very good test, so hepatitis A IgM for acute viral hepatitis diagnosis has been allowed and recommended in the program. So this is for if a patient, this is the guidelines. If you have a patient who is jaundice, means there is an acute hepatitis happening, then you can test the patient for B, C, A, and E. B and C surface antigen, although IgM core has been written here in the national program guidelines, and I have taken this chart from there. But the budget, this is something very confusing even to me, that whether they're going to provide you with the IgM anti-HBC assays, because whatever guideline says HBsAg and DNA, but still it is written. So maybe IgM anti-HBC will be done in case it's a patient is already jaundiced and it is looking like an acute jaundice. For HCV, only antibody. For A and E, IgM A and IgM anti-HEV will be done. And they will be referred to model treatment center for follow-up and treatment initiation. Now, if the patient is without jaundice, means asymptomatic, then only testing for B and C will be offered. For B, surface antigen, and for C, only antibody to C. And as I told you, as per that guidelines, the patient is going to be followed up. So this is in nutshell the guidelines which has been made. So I told you that there is a national viral hepatitis control program. There are guidelines made. Budget is there with the government of India. States have to now some work in identifying the nodal officer, state viral hepatitis unit, which centers are going to be treating the uncomplicated cases, which are going to treat complicated cases. Where are you going to give budget for RT-PCR? I think Punjab, Haryana have taken up, even Uttarakhand has taken up, but Delhi state has still not taken up the program, and we have still not identified the sites how the flow is going to be there. So there are a lot of hindrances. I'm sure in the coming year, 2020, 22, and 2023, most of the states will take up this program. So any patient who is infected with B and C, you can just tell them that please, if you want to come to a private center, fine, but you have to pay. Otherwise, these are the sites where free testing and free drugs are going to be made available, so the patient can go and get their free treatment and diagnosis. So we have to find cases, link them to care, and follow up them as per the guidelines. This is a decentralized. So in Delhi, we actually started before the program in 2019 and 20. Let's start testing and giving free care and show to Delhi government that we can do. We took a lead from ILBS that we do, and we actually checked for 38,000 patients. We did their RNA, we put them on treatment, and we could attain an SVR of 95%. This and in 1 year span time, we could actually treat. So if you actually identify sites, you make an RT-PCR test available, you identify clinicians and labs, actually you can screen so many patients in a year and put them on treatment. So the problem of hepatitis C elimination by 2030 can be easily attained. So the current center is at 710. This is from the Government of India sites. They have identified 710 centers, and they are saying that they are functional. Now, whether they are functional from the treatment point of view or test, I'm not still aware. As per the Government of India site, 75 lakh have been screened and they have been put on treatment, maybe in the Northeast, Punjab and Haryana. And Delhi, as I showed you, 37,000, but that was through our effort. And now we are also sitting because we are waiting for the government of Delhi to tell us whether to go ahead or not to go ahead. So consolidated smaller projects and state programs and the national program for harmonization. We testing for pregnant women also they are identifying. And another thing they are trying to say, which is not there, is vaccination of healthcare workers under this program. So this is the current status of the national program. So I would just like to summarize that although the WHO's target are not very, very difficult to achieve, where you have to reduce the mortality and new infections, but National Program Hepatitis Control Program in India has been launched because of that. But one has to enhance the diagnostics and has to make a good plan by the state so that it works and more people know about that there is a program happening where they can send the patient for free testing and free treatment. So I thank you all, and if you all know from in your state wherever this program is working, do let us know that yes, I have seen this site working and they're doing free testing and treatment under the program. Thank you.